This is a two-view chest radiograph of a 42-year-old woman presenting with shortness of breath. The radiographs show increased opacification of the lower and lateral aspect of the left hemithorax, with a smooth upper margin forming a meniscus, consistent with a pleural effusion. There is rightward mediastinal shift and depression of the left hemidiaphragm, indicating a large effusion exerting mass effect. On the corresponding CT, the mass effect is more clearly seen, and there is a small pleural-based nodule along the anterior pleura, suggesting an underlying malignant etiology. A large unilateral effusion of this magnitude should immediately raise suspicion for malignancy, infection such as empyema, or trauma causing a hemothorax. Less common causes include hepatic hydrothorax in patients with cirrhosis, or rarely a chylothorax or glucothorax from an iatrogenic cause, such as a misplaced central line. Large unilateral effusions are very unusual in congestive cardiac failure, which typically causes bilateral effusions, so the presence of a single-sided effusion of this size should prompt further evaluation for alternative causes. The key teaching point here is that a large effusion can act physiologically like a tension pneumothorax. The mass effect of the fluid compresses the contralateral lung and shifts the mediastinum, impairing venous return to the heart and potentially leading to cardiorespiratory compromise. The depression of the hemidiaphragm and contralateral shift of the mediastinum in this case indicate tension physiology. If the patient is hemodynamically unstable, this finding requires urgent drainage. If stable, further characterization with CT is appropriate both to confirm the extent of the effusion and to look for underlying pleural nodularity or thickening suggesting malignancy, as well as to plan thoracostomy tube placement. A decubitus film with the affected side down can help determine whether the fluid is free-flowing or loculated, although in a large effusion, there may be little positional change. In summary, these findings represent a large left pleural effusion with mediastinal shift and diaphragmatic depression, producing a tension effect. The presence of a pleural nodule on CT strongly suggests a malignant etiology. This is an important diagnosis to recognize, as tension-type effusions can be life-threatening and require prompt communication and appropriate management.